Hey, it's Rob Fitzgerald again. Welcome back to Quick Hits in Lab Medicine. I've got about 11 slides on thyroid disease and our screening test. It's October 1st here in Southern California. It's a beautiful day outside. Surf is 2 to 4, glassy, 15-second period. I want to get out of here. I know you're busy. Let's get started. So, talk a little bit about signs and symptoms of thyroid disease, some of the primary illnesses associated with the thyroid gland, and our screening test. So thinking about what does the thyroid gland do? It increases basal metabolic rate. That's sort of its primary function, and in doing that, it's going to cause weight loss. It causes tremor, so fine tremor in the hand, causes tachycardia and arrhythmias. That's a problem of both clinical hyperthyroidism and subclinical hyperthyroidism. It causes fatigue. Patients are always hot. They're always sweating. They're trying to find places to get cool. Oftentimes they have diarrhea. They're nervous. They're irritable. They have scant menses for females. They're hot, so they have moist skin. They have hyperactive deep tendon reflexes. Oftentimes they will have an enlarged neck, and so we call that goiter. So that's the swelling of the neck, and physicians are going to be examining the neck for their thyroid gland. Signs and symptoms of hypothyroidism are sort of the opposite picture. So they're lethargic, they don't have any energy, they're gaining weight, they have dry skin, they get puffy eyes. So they get what's called exophthalmos. And basically it's bulging out of the eyes, and that's due to autoimmune processes that's causing inflammation. They typically have really thin hair. They're cold, they have low body temperature, they are easily fatigued, they get dizzy. Their voice hoarsens because of the swelling and the enlargement of the thyroid gland. There's clearly CNS effects. Depression is common, loss of libido, and sometimes they're also anemic. So the diseases that readily come to mind for thyroid are Hashimoto's. And so Hashimoto's is an autoimmune disease where you get antibodies attacking the thyroid gland. And so it is the most common cause of hypothyroidism. And these patients, typically they're hypothyroid, but as the disease is manifesting and the antibodies are starting to destroy the thyroid tissue, they can go through a hyperthyroid stage because you're releasing existing thyroid gland tissue along with thyroid hormones. Plummer's disease is a functional adenoma of the thyroid. So they talk about this as toxic multinodular goiters. And so these are focal areas of the thyroid gland where you have a mutation that activates the TSH receptor. So the TSH receptor stays on, and these are secreting excess T4 that sort of is independent of the feedback of TSH. So in this case, you're going to have an elevated free T4, but you can have a low TSH. Another reasonably common cause of hyperthyroidism is Graves' disease. Graves' disease is interesting because it's caused by an immunoglobulin that binds to the TSH receptor in the thyroid gland. So why is an immunoglobulin able to activate a TSH receptor? I don't know. But it's not subject to the negative feedback, and so it causes diffuse goiter. It causes an enlargement of the thyroid gland and excess release of thyroid, and these patients get thyrotoxicosis. So it's a cause of hyperthyroidism. Screening test, neonatal thyroid screening was one of our first newborn screening tests. Congenital hypothyroidism is about 1 in 4,000 patients. It's easily treatable. It can prevent a lifelong illness if it's identified early, and so it's part of our newborn screening where it's done by a heel stick, a blood spot, and we screen for a variety of illnesses, including thyroid disease. So if we identify that early enough on, we can supplement with levothyroxine, and we can prevent the severe intellectual problems that happen in the absence of thyroid disease, in the absence of thyroid hormone. So 3 to 5 day old infants get a heel stick, get a blood screen, and we measure both the T4 and a TSH. And if they're abnormal, then they get a more thorough workup and supplementation. Adult population screening. It is a commonly ordered test in primary care. It should be done, 1 to 2% of the population. Some people say 7%, higher prevalence in women. There is clearly effective treatment. We can supplement with levothyroxine. We can monitor that with looking at the TSH and the feedback and make sure that they are appropriately treated. It's best done as an outpatient because we want to do it in the absence of acute illness, because acute illness is going to have an effect on your TSH and your free T4. And so we want to try to do it with the least confounding factors and done as an outpatient screen. And again, we screen with the TSH and we follow that up with a free T4. That's good for the vast majority of patients. So you do a TSH. If the TSH is normal, you're done. If your TSH is abnormal, you follow it up with a free T4. Again, the TSH being sort of a biological indicator of active thyroid hormone, and so it's telling us, do we have enough active hormone? So we have defined hypothyroidism as a low free T4 and an elevated TSH. Subclinical and hyperthyroidism is an elevated free T4 and a low TSH. Subclinical hyperthyroidism is a combination of an undetectable TSH but a normal free T4. So, not all of these thyroid function tests most are interpretable in a straightforward manner, but in the cases of, for example, subclinical hyperthyroidism, your TSH, your biological feedback is saying you have too much, but your free T4 is normal. And so what do we do with this? A lot of that depends on what kind of symptoms are present, and the clinician's, gestalt of how the patient is doing. So prevalence of about 2%, so reasonably high prevalence in the population. If the TSH is suppressed, so it's not undetectable, so whenever we say less than something, that means that the laboratory test cannot measure any lower. So it's at least that low. Between the undetectable and the bottom of the normal range, they could still be hyperthyroid, but it's not considered subclinical unless their TSH is undetectable. So patients that have a TSH that is suppressed, that's undetectable, oftentimes they will be put on antithyroid medications. Subclinical hypothyroidism is sort of the other side of that, where we have an elevated TSH but still a normal free T4. So it seems like the T4 is not able to feed back on the pituitary sufficiently. Again, a reasonably high prevalence in the population, 5 to 10% have subclinical hypothyroidism. Women, it's even higher. And generally, most clinicians would start to treat people. They would supplement with levothyroxine, that's T4, if they have a TSH greater than 10. Upper range of a TSH, is debatable. Different labs use different ranges, and there's still no good consensus in the community. But some people will say 2.5, some people will say 4.5 as the upper end for a TSH. We use 4.5. So between 4.5 and 10, whether treatment is given, really depends on the clinician and obviously the patient. So. For Graves' disease, basically that's hyperthyroidism due to thyroid-stimulating immunoglobulin. Basically, you want to reduce the production of the thyroid hormones. That can be done by drugs, so propylthiouracil, methimazole, something like that. Radioactive iodine. So iodine is used both to scan the thyroid and to treat the thyroid. So when you're trying to see if you have diffuse goiter and diffuse activity of the thyroid gland versus a nodular, a focal area of activity in, say, Plummer's, you could give a small dose of radioactive iodine. The thyroid gland takes it up, and the active parts of the thyroid gland are going to concentrate that radioactive iodine. So you can image that, and you can see if you have multinodular or if you have diffuse goiter. And if you have, excessive uptake than what is normal. So that would be a diagnostic dose. If you have hyperfunctioning of the thyroid gland, you can give radioablating doses of iodine. Those are high enough concentrations that they actually kill the tissue, and that's also a treatment. So surgery is also an option. Thyroidectomy is reasonably common for thyroid cancers. Symptomatic treatment, propranolol is a beta blocker, so it's going to have some effect on the hypertensive activity of thyroid glands. It's also going to decrease the conversion of T4 to T3, so it inhibits that peripheral deiodination and is ineffective in both of those modalities. So as a summary, for thyroid disease, we do a sensitive TSH. If it's normal, we're pretty much done. No further testing is generally needed. If our TSH is elevated, that says we don't have enough thyroid gland to feed back on the pituitary and hypothalamus, and so we're suspecting they're hypothyroid. We're going to measure our free T4 and confirm that. If they are hypothyroid, they typically get put on thyroid replacement, levothyroxine. If it's undetectable or subnormal, that's suggesting you have too much thyroid hormone. And we're going to follow that TSH up with a free T4. If the free T4 is high, then they're going to further triage that patient. So that's a quick overview of the signs and symptoms of thyroid disease, the most common thyroid diseases, and our basic screening and strategy. Thanks for listening.